Good morning, everyone. I'll be polygenic risk factors for hepatocellular carcinoma. In risk of hepatocellular carcinoma, there is genetic heterogeneity involved. There are various environmental factors involved in causation of HCC, like hepatitis viruses, alcohol, cigarette smoking, etc. And there are diseases which are inherited as polygenic traits and show increased risk of hepatocellular carcinoma as compared to general population, which include autoimmune hepatitis, type 2 diabetes, family history of hepatocellular carcinoma, hypothyroidism, NASH. So this diagram shows that there are genetic factors like porphyrias, alpha-1 antitrypsin deficiency, tyrosinemia, hemochromatosis, and along with lifestyle related factors or genetic factors like NASH, autoimmune hepatitis, diabetes type 2, and leading to cirrhosis and then eventually to HCC. So this shows that monogenic syndromes along with polygenic factors contribute to causation of HCC. About individual susceptibility to HCC, in a general population, it includes subjects at high genetic risk of HCC. These colored ones are the ones with genetic risk, and on exposure to environmental factors like hepatitis viruses, alcohol, the subjects develop HCC. These may be in the presence of environmental factors or even without environmental factors, and even without genetic risk, subjects can develop HCC. So there is a lot of genetic heterogeneity in HCC. This is from our institute work. So it shows the progression of HCC from a normal to inflammation and cirrhosis. There are dysplastic changes, and then HCC develops in a cirrhotic background. So this concept is coming up of polygenic risk score in NAFLD, NASH associated HCC. The prevalence and incidence of NAFLD is increasing due to the epidemic of obesity and type 2 diabetes mellitus. NAFLD is a multi-system disease with hepatic and extrahepatic manifestations. The stratification of risk of NAFLD related HCC is based on clinical and genetic evidence, and it is required for prevention, prediction, and surveillance of HCC. The whole thing is a multifactorial process involving factors like obesity, type 2 diabetes, hypertension, ethnicity, genetic polymorphism, epigenetic factors, transcriptional factors, post-transcriptional modification, hepatic lipogenesis, and carcinogenesis. This depicts the polygenic risk score for risk stratification and prediction for severe liver disease. This clinical data like age, overweight or obesity, diabetes, dyslipidemia, liver function tests, these are deciding the clinical fibrosis scores into low risk and intermediate to high risk. And then there are this genetic predisposition, genetic changes, which are these 4 genes, and all this define into polygenic risk score into high and low, and this leads to fatty liver from normal liver and then to cirrhosis. So this risk score can define the risk of HCC in different stratified group of patients. So this polygenic risk score with hepatic fat content, this study showed that it improved diagnostic accuracies and positive predictive values for severe liver disease in intermediate to high clinical score risk classes. So HCC risk stratification in individuals with dysmetabolism. It is required in cases of NAFLD because these cases are rising, and these patients are at risk for HCC. So to identify which ones develop HCC is required. So this study divided patients into an NAFLD cohort, which included 2566 cases, and in which 226 were with HCC. This cohort was compared with a UK biobank cohort, which comprised of general population with all data available, and this was 3,64,000 patients, and in which 202 with HCC. So these genotypes were studied in this group of patients, and there were variants in these 3 single nucleotide polymorphisms, these 4 genetic changes in PNPLA3, that is patatin-like phospholipase domain containing protein 3, transmembrane 6 superfamily member 2 TM6SF2, membrane-bound O acyl transferase domain containing 7 MBO87, and glucokinase regulator GCKR. These factors, and along with demographic and lifestyle factors, were studied for a polygenic risk score, defining the hepatic fat content. In the NFLT cohort, it was seen that adjusted impact of genetic risk variants on HCC was proportional to predisposition to fatty liver. This polygenic risk score predicted HCC in severe fibrosis and also in those without severe fibrosis. So this risk score can predict HCC in severe fibrosis and even in patients without severe fibrosis. This area under curve, receiver operating curve cutoff was calculated, and it showed 43% sensitivity and 80% specificity. So this was in the NAFLT cohort. And in case of UK Biobank cohort, polygenic risk score predicted HCC independently of classical risk factors and cirrhosis. So and the AURC cutoff was showed 27% sensitivity and 90% specificity. So in patients with cirrhosis or without cirrhosis, so this score can predict the risk of HCC. This is another study which has studied this polygenic risk score in East Asian population, because all that previous data was in European cohort. So in East Asian population, it included participants of the Singapore Chinese health study. There was a structured questionnaire for demographic and lifestyle characteristics, and these patients had donated their blood, buccal and or urine samples. So among these cohort, 208 incident cases of HCC in the genotype subcohort were there. And in same way, this hepatic fat content polygenic risk score and NAFLT polygenic risk score was devised, and it showed significantly increased risk of HCC with a hazard ratio of 2.39 and hazard ratio of 1.77 respectively for HFC PRS and this NAFLT PRS. So this was about polygenic risk score, and seeing our patients, our institutional group of patients. This is 115 patients who were treated with radiotherapy in our department. So this showed the majority of the patients belong to the age group of 51 to 70 years, that is 87, and the rest of the patients were in other groups like 33 to 45 years, 46 to 50, and 71 to 80. And among these group also, most were with between 60 to 70. Most were males, and non-cirrhotic was very few, 3 cases, and CLD was in 112 cases. So the profile of CLD in our patients was as follows. NASH was most commonly seen in 44 cases, followed by hepatitis B virus in 32 cases, and then hepatitis C virus 17 cases. Alcohol liver disease 5, cryptogenic 3, and rest were combination with few cases. So our data shows that this NASH is the most common cause of CLD, which is leading to HCC. This is some of our institutional work which Dr. Gayatri has shared, and it shows that EpCAM positive liver cancer stem-like cells exhibiting autocrine Wnt signaling potentially originate in cirrhotic patients. So we can have our own Indian data and markers which can define our HCC data further. And this is another work, our institutional work, where the team, this molecular medicine team, have studied this beta-catenin mutation in exon 3, and it was seen in positive in cold tumors and hot tumors. So further defining HCC cases can have implications on therapeutic strategies that we use. This is another one, senescent cells in HCC microenvironment. which modulate macrophage polarization. So this was the that literature I could work on the polygenic risk factor. We can do more. We can have some ideas on based on this, and we can apply this NAFLD or hepatic fat polygenic risk score, and in our Indian population, and it can ascertain HCC risk stratification because we have this chronic liver disease patients. Thank you.